Welcome to our session on thermoregulation. This topic might seem basic, but it's absolutely critical for neonatal care and will absolutely appear on the exam. Understanding how tiny babies maintain their temperature and how we can help them when they can't is fundamental to everything we do. Let's explore the key concepts that will be important for both your practice and the exam. By the end of this presentation, you should be able to identify the mechanisms of heat loss and production in neonates. Understand what constitutes a neutral thermal environment, explain how to manage hypothermia and hyperthermia, review thermoregulation considerations during transport and in the delivery room, and discuss various temperature monitoring methods. These objectives align directly with commonly tested areas on the certification exam, so pay close attention to these concepts. Thermoregulation is the foundation of neonatal care. Simply put, it's how the neonate balances heat generation and heat loss in a changing environment. This balance is a critical component in the physiologic adaptation to life outside the womb. The World Health Organization and Neonatal Resuscitation Program emphasize temperature management because hypothermia after delivery is a worldwide issue, regardless of climate. Cold stress significantly contributes to neonatal morbidity and mortality. The infants at highest risk include those less than 28 weeks gestation, birth weight under 1,500 grams, intrauterine growth restriction, infants affected by maternal sedation, those with neurologic complications like asphyxia, and those with open defects. Remember this risk list. It comes up frequently on the exam. Neonates face several physiological challenges when it comes to maintaining temperature. First, they have minimal subcutaneous fat for insulation. Second, and this is really important for the exam, they have a large surface area to mass ratio compared to adults. For term neonates, this ratio is actually 3 times greater than an adult. They also have lower capacity for heat storage and poorer vasoconstrictor control, especially in preterm infants. The hypothalamus, which regulates temperature, is immature. Newborns can't shiver effectively to generate heat like we can, and their thin, permeable skin allows significant transepidermal water loss. Put simply, they're designed to lose heat quickly and struggle to produce it, a dangerous combination that makes our interventions so important. Now, let's talk about how babies actually produce heat. The primary method is nonshivering thermogenesis, or NST. This is triggered when skin temperature drops below 35 to 36 degrees Celsius. This process relies heavily on brown adipose tissue, or BAT, which is severely limited in extremely low birth weight infants. This is frequently tested, so remember that brown adipose tissue begins developing at around 26 to 28 weeks gestation. It's located in the interscapular region, neck, axilla, and around organs like the kidneys and adrenal glands. BAT is highly vascularized and innervated by sympathetic neurons. Unlike white fat, which primarily stores energy, brown fat is designed to burn energy and generate heat. Let's break down exactly how non-shivering thermogenesis works, because this is tested often. When a baby gets cold, temperature receptors send signals that increase sympathetic output from the central nervous system. This results in norepinephrine release. Remember this neurotransmitter? It's important. Norepinephrine stimulates beta-adrenergic receptors in brown fat, which increases cyclic AMP production and activates lipolysis. This process can increase metabolic rate up to 3-fold when maximally stimulated. It requires adequate glucose, oxygen, and brown fat stored. Here's a critical concept that appears frequently on the exam. This process produces metabolic acids as a byproduct. So, cold stress leads to metabolic acidosis, not alkalosis. That distinction is often tested, so commit it to memory. Babies lose heat in 4 main ways, and you'll definitely see questions about these mechanisms. First is radiation, which accounts for about 40% of heat loss. That's heat transfer to cooler objects without direct contact. Second is evaporation, heat loss through vaporization of moisture from the skin surface. Third is convection, heat loss to air currents moving across the skin. And fourth is conduction, direct transfer of heat to cooler objects in contact with the baby. Understanding these different mechanisms helps us implement the right interventions to prevent heat loss. I guarantee you will have a question or multiple questions about heat loss. The structure may be presenting an infant in a situation and asking you to identify the primary heat loss mechanism at work. Alternatively, they like to present an infant and ask you to identify the best strategies for preventing heat loss given an infant situation or scenario. Evaporative heat loss occurs when water vaporizes from the skin's surface. This is especially significant in extremely preterm infants due to their thin, permeable skin. Transepidermal water loss, or TEWL, is inversely related to gestational age. This relationship is frequently tested. At 25 weeks gestation, an infant has about 15 times greater TEWL than a term infant. That's huge! Prevention strategies include immediately drying the baby after birth, except for very premature infants, who should be placed in plastic bags without drying. Using plastic wraps for very low birth weight infants. Increasing ambient humidity, especially for babies less than 32 weeks. And delaying the first bath. Remember, evaporative losses are inversely related to ambient humidity. Higher humidity means less evaporation. Convective heat loss occurs when heat transfers from the baby's skin to surrounding air currents. It's affected by airflow, ambient temperature, and the amount of exposed skin surface. To prevent convective heat loss, avoid drafts and air conditioning vents. Swaddle the baby when appropriate. Keep incubator portholes closed when possible, and pre-warm oxygen and respiratory gases. You might see scenarios on the exam where convective heat loss is occurring, and you'll need to identify the appropriate intervention. Conductive heat loss happens through direct heat transfer from the baby's skin to cooler objects in contact with them. While this generally contributes less to overall heat loss than radiation or evaporation, it's still important to address. Prevention strategies include pre-warming surfaces like scales and X-ray plates, using warmed mattresses and linens, employing trans-warmer mattresses, and implementing skin-to-skin care. The exam might present a scenario where a baby is placed on a cold surface and ask you to identify what type of heat loss is occurring. That would be conduction. The neutral thermal environment, often abbreviated as NTE, is the temperature range where the infant's metabolic rate and oxygen consumption are minimal while still maintaining a normal body temperature. It's also called the thermoneutral zone or zone of thermal comfort. This concept is frequently tested. The benefits of maintaining babies in their NTE include minimizing caloric expenditure for temperature regulation, which optimizes growth and weight gain, reduces oxygen consumption, and promotes overall stabilization. Think of it this way. Every calorie the baby doesn't have to spend staying warm is a calorie that can go toward growth and development. Several factors influence what temperature constitutes a neutral thermal environment for a particular infant. These include gestational age and birth weight, postnatal age, clinical condition, environmental humidity, proximity to outside walls or windows, and the use of clothing and positioning devices. Here's a clinical pearl that's worth remembering. Smaller infants require higher environmental temperatures to maintain their neutral thermal environment. This makes sense when you consider their larger surface area to volume ratio and limited heat production capabilities. Questions often ask you to identify which baby needs the highest environmental temperature, and it's usually the smallest or most premature. Absolutely need to know these normal temperature ranges for the exam. For full-term infants, 36.5 to 37.5 degrees Celsius, or 97.7 to 99.5 degrees Fahrenheit. For preterm infants, 36.3 to 36.9 degrees Celsius, or 97.3 to 98.4 degrees Fahrenheit. For very low birth weight infants, 36.7 to 37.3 degrees Celsius, or 98.0 to 99.0 degrees Fahrenheit. The World Health Organization classification of hypothermia is also frequently tested. Cold stress or mild hypothermia is 36.0 to 36.4 degrees Celsius. Moderate hypothermia is 32.0 to 35.9 degrees Celsius, and severe hypothermia is below 32 degrees Celsius. Commit these numbers to memory. They come up often on the exam. The metabolic consequences of cold stress are heavily tested on the exam. When a neonate experiences cold stress, a cascade of physiological responses occurs. First, peripheral vasoconstriction happens as the body tries to conserve heat. This leads to increased oxygen consumption and increased glucose utilization as the baby burns more energy to generate heat. Remember, the metabolic rate can increase up to 3-fold. This process leads to metabolic acidosis, which is a key point. Other consequences include pulmonary vasoconstriction, hypoxia, and surfactant dysfunction. Together, these changes can significantly impact a neonate's clinical status and increase morbidity and mortality. This is a critical distinction that appears on the exam: how to differentiate between environmental hypothermia and sepsis. With environmental hypothermia, you'll typically see warm trunk and extremities, a flushed or ruddy appearance, and vasodilation. In contrast, sepsis typically presents with cool extremities, creating a temperature gap between the trunk and extremities, a pale or mottled appearance, and vasoconstriction. Here's another frequently tested concept: increased heat requirements in an infant who previously maintained temperature well may indicate sepsis. If an infant suddenly needs higher incubator temperatures despite appropriate interventions, think infection. Radiant warmers provide overhead infrared heat and use a skin probe for servo control. They're excellent for providing accessibility during procedures, offer rapid warming capability, and allow good visibility for assessment. However, they have disadvantages, including increased insensible water loss, greater convective losses, and the risk of overheating if the probe becomes detached. The temperature probe itself, not the skin temperature, controls heat output. This distinction sometimes appears on exams. Also remember that radiant warmers should always be used with servo control to prevent overheating. Incubators come in single-walled or double-walled varieties, with double-walled models providing better insulation against radiative heat loss. They can be operated in 2 control modes: air mode, manual control, or skin servo control, with servo control being preferred because it responds to changes in the infant's skin temperature. Advantages of incubators include reduced evaporative, conductive, and convective losses, plus the ability to add humidity. Disadvantages include limited accessibility and temperature drops when doors are opened. For the exam, remember that both incubators and radiant warmers have been shown to be equally effective when used properly. Humidity is particularly important for very low birth weight infants, especially during the first week of life. Benefits include reducing evaporative heat loss, decreasing insensible water loss, and supporting skin integrity. However, and this is frequently tested, increased humidity also increases the risk of Pseudomonas infections, particularly when condensation forms on incubator walls. Avoid condensation at all costs. Humidity is typically used for 1 to 2 weeks until skin barrier maturation develops, which may take longer in extremely premature infants. The exam often asks about the risks of incubator humidity, so remember the Pseudomonas connection. The delivery room is where thermoregulation interventions begin, and these initial steps are critical. Maintain delivery room temperature at 72 degrees Fahrenheit, 25 degrees Celsius, or higher. Preheat the radiant warmer and linens before the baby arrives. Immediately dry the baby, except for extremely low birth weight infants who should be placed under plastic without drying. Use plastic wrap or bags for preterm infants. Apply warm hats to reduce heat loss from the head. Have a pre-warmed transport incubator ready. Remember that the golden hour protocol emphasizes prevention of hypothermia as a primary goal. These delivery room interventions are frequently tested, so know them well. Transport is a vulnerable time for neonatal thermoregulation. Always preheat the transport incubator and use servo control during transport. For very low birth weight infants, plastic wrap provides additional insulation. Avoid exposing the baby to cold environments during transfers between units or facilities. Monitor temperature continuously throughout transport. Be aware that temperature drops commonly occur during transfers into and out of the transport incubator. The exam frequently asks about recognizing signs of hypothermia during transport, so be familiar with these: lethargy, weak cry, apnea, bradycardia, and poor perfusion. When managing hypothermia, gradual rewarming is generally preferred over rapid rewarming. Set the skin temperature about 1 degrees E above the current temperature. Monitor vital signs every 30 minutes during rewarming. Watch for hypotension as vasodilation occurs during the rewarming process. Supportive measures include oxygen supplementation as needed, careful fluid management, frequent glucose monitoring to prevent hypoglycemia, and considering a sepsis evaluation if the infant doesn't respond to warming as expected. The exam often presents scenarios requiring you to identify the appropriate rewarming approach. Though less common than hypothermia, hyperthermia management is still important to understand. Common causes include environmental factors like excessive radiant warmer settings or excessive swaddling, maternal fever, infection or sepsis, and dehydration. Management involves removing external heat sources, gradually lowering the environmental temperature, monitoring fluid status closely, and ruling out infection. Hyperthermia increases metabolic demands and oxygen consumption. Remember that servo-controlled incubators will have decreased heater output in response to rising skin temperatures, which can mask fever from infection. The standard method for monitoring neonatal temperature is axillary measurement. It correlates well with core temperature, is minimally invasive, and normal values are 36.5 to 37.5 degrees Celsius for term infants and 36.3 to 36.9 degrees Celsius for preterm infants. Skin probes provide continuous monitoring and are typically placed on the right upper quadrant of the abdomen with normal values around 36.0 to 36.5 degrees Celsius. Avoid rectal temperature measurement due to the risk of perforation. An important concept that's often tested. A drop in skin temperature may be the first sign of hypothermia, while core temperature may not fall until the infant can no longer compensate. Knowing when and how to wean an infant from an incubator to an open crib is an important clinical skill. Criteria for readiness include physiological stability, at least 32 weeks corrected gestational age, weight of 1,500 grams or more, caloric intake of at least 100 calories per kilogram per day, and consistent weight gain. The weaning process involves dressing and capping the infant, gradually decreasing the incubator temperature, and closely monitoring axillary temperature. Remember that premature infants who are weaned too early or experiencing cold stress may demonstrate poor weight gain despite adequate caloric intake. This concept is tested on the exam. Skin-to-skin care, also known as kangaroo care, offers numerous benefits for thermoregulation. It's proven effective for maintaining temperature in stable, preterm infants, even those on ventilators. The benefits extend beyond just thermoregulation to include enhanced physiologic stability, promoted bonding, facilitated breastfeeding, improved sleep patterns, and pain relief. Safety considerations include continuous temperature monitoring and careful attention to the transfer process. Studies show that during skin-to-skin care, mothers exhibit thermal synchrony with their infants, adjusting their own body temperature to maintain the infant's thermal neutrality. Before discharge, families need education about thermoregulation. Teach them how to take accurate axillary temperatures and what normal ranges are. Explain appropriate clothing for different ambient temperatures. A good rule of thumb is that babies need one more layer than adults. Teach signs and symptoms of illness related to temperature and when to call the healthcare provider. Caution against both overheating and overbundling. One common issue is that parents often overdress infants or overheat their homes, which can cause hyperthermia, so this education is essential. Let's review key points that frequently appear on the exam. Brown fat production begins at 26 to 28 weeks gestation. Radiation accounts for 40% of heat loss. Cold stress leads to metabolic acidosis, not alkalosis. Hypoglycemia is a consequence of cold stress due to increased glucose consumption. Humidity reduces transepidermal water loss, but increases the risk of Pseudomonas infections. Servo control is the preferred method for incubator management. Increased heating requirements in a previously stable infant may indicate sepsis. These concepts appear repeatedly on the exam. so be sure you understand them thoroughly. A preterm neonate at 27 weeks gestation is experiencing cold stress. What physiological response would you expect to observe? Metabolic alkalosis due to decreased carbon dioxide production. Metabolic acidosis due to increased fatty acid metabolism. Respiratory acidosis due to decreased ventilatory effort. The correct answer is metabolic acidosis due to increased fatty acid metabolism. This question is testing your understanding of the metabolic consequences of cold stress in neonates. Metabolic acidosis develops during cold stress because non-shivering thermogenesis increases fatty acid metabolism from brown fat, producing acidic byproducts. This metabolic pathway requires increased oxygen consumption and glucose utilization, resulting in the production of metabolic acids. Metabolic alkalosis is incorrect because cold stress causes acidosis, not alkalosis. Respiratory acidosis is incorrect because cold stress primarily affects metabolic pathways rather than directly causing hypoventilation. Which mechanism of heat loss is primarily reduced by increasing humidity in the incubator of a 24-week gestation neonate? Conductive heat loss through direct contact with cooler surfaces, convective heat loss from air currents across the skin surface, evaporative heat loss through transepidermal water loss? The correct answer is evaporative heat loss through transepidermal water loss. This question is testing your knowledge of how humidity affects specific mechanisms of heat loss. Increasing humidity reduces evaporative heat loss by decreasing the gradient for water vapor movement from the skin to the environment. This is particularly important in extremely premature infants who have significantly higher transepidermal water loss due to their thin, permeable skin. Conductive heat loss is incorrect because humidity doesn't significantly affect heat transfer through direct contact. Convective heat loss is incorrect because humidity primarily affects evaporation, not convection from air currents. A previously stable 9-day-old former 26-week infant suddenly requires increased incubator temperature settings despite all warming interventions. The infant develops tachycardia and hypotension. Which condition should the NNP most suspect? Intraventricular hemorrhage with autonomic instability, nosocomial sepsis with systemic inflammatory response, patent ductus arteriosus with increasing shunt. The correct answer is nosocomial sepsis with systemic inflammatory response. This question is testing your ability to recognize sepsis presentation through changes in thermoregulation requirements. Increasing incubator temperature requirements despite appropriate interventions is a classic early sign of sepsis in neonates. When combined with tachycardia and hypotension, this strongly suggests a systemic inflammatory response from infection. Intraventricular hemorrhage is incorrect because while it can cause autonomic instability, it typically doesn't present with increasing temperature requirements as a primary symptom. Patent ductus arteriosus is incorrect because while it can cause tachycardia and hypotension, it doesn't typically present with increased temperature requirements. Which risk factor most significantly increases a neonate's susceptibility to hypothermia? Delayed first bath beyond 24 hours of age, large surface area to body mass ratio compared to adults, presence of maternal fever during labor and delivery. The correct answer is large surface area to body mass ratio compared to adults. This question is testing your understanding of the physiologic factors that make neonates vulnerable to heat loss. The large surface area to body mass ratio, approximately 3 times greater than adults, is a fundamental physiologic characteristic that makes neonates particularly vulnerable to heat loss. This factor significantly increases the rate of heat exchange with the environment. Delayed first bath is incorrect because this actually helps prevent hypothermia, not increase risk. Maternal fever is incorrect because it typically causes neonatal hyperthermia initially, not hypothermia. A double-walled incubator is most effective at reducing which mechanism of heat loss? Conductive heat loss to the mattress surface, evaporative heat loss through skin surface, radiative heat loss to nearby cooler surfaces. The correct answer is radiative heat loss to nearby cooler surfaces. This question is testing your knowledge of specific equipment features and their impact on thermoregulation. Double-walled incubators specifically reduce radiative heat loss by providing an additional barrier between the infant and the cooler outer walls. Radiation accounts for approximately 40% of heat loss in neonates, making this an important feature for thermal management. Conductive heat loss is incorrect because double walls don't significantly impact heat transfer to the mattress. Evaporative heat loss is incorrect because humidity, not double walls, is the primary intervention for reducing evaporative losses.